First, let's start with Josh, and then go over to Christine, because we're really fortunate to have the director here tonight to talk about his experience. Thanks, Josh.
Sure, so I'm just introducing myself.
And say what's important to you about the film.
Yeah, okay, so, Josh Savy. I wrote and directed the film. My mom was actually the heart behind the film. She came up with the concept and was the heart. I was the workhorse. So. But it was a family experience that began. My sister had anorexia for 7 years, and just in the process, we went many different treatment centers, and after 7 years, we realized that not one had used, really the gold standard treatment, and that was just appalling to us. And then as we did more and more research, we found out this is a problem at large in the mental health field, not just with anorexia. So we tried to address the field of mental health with this documentary. So, yeah.
Christine? Yeah.
Oh, sure.
Closer.
Hi, I'm Dr. Christine Pete. I'm a clinical psychologist at the UNC Center of Excellence for Eating Disorders. And for this evening, in terms of what hat I'm going to be wearing, I am a clinician that works directly with patients, and I'm also someone who's involved in research. So I'm kind of the living embodiment of that bridge over that gap between research and clinical practice.
Okay, and I'm Cynthia Benet. I also have a few hats, and I'm happy to wear all of them tonight. I've been a healthcare professional my entire career. First started out in nursing, working in the hospitals, and then got into clinical research at the Duke Clinical Research Institute. I know I'm in enemy territory, so I'll lay low. But I also my husband and I are the parents of a child born with congenital heart disease, so used to battling chronic illness and insurance companies his entire life, but he was subsequently diagnosed after graduating from college with schizoaffective disorder. And so that was probably the most dramatic thing that's happened in our life, and it's changed our careers. Another hat that I wear currently is I'm the chair of the board of directors for Alliance Behavioral Healthcare, which is one of the 7 managed care organizations in the state and the public system caring for the Medicaid and uninsured population with behavioral health issues.
Thank you, Cynthia. No, my name is Ed Benet. I'm Director of Development at the UNC Community Mental Health. And this film really is like PTSD for me. As Cindy indicated, our son, after graduating from college 13 years ago from a university that a lot of you don't like, called Villanova, had been diagnosed with schizophrenia. I'm not diagnosed, but had a mental break. And since my wife works at Duke, we decided to bring David, my son, to Duke, and he stayed there for 22 days. And actually, the Duke people said, go to UNC. They have a very good, robust psychiatry department with evidence-based type treatment. So we moved to UNC, and again, it's been 13 years ago, and David now is married. They have a wonderful baby, Chloe, and he's really improved, and I'm very glad that we moved to UNC, and very proud the fact that we changed careers, as Cindy said. I tried to be an advocate for the mentally ill patients and clients, and at the same time also advocate in Raleigh for mental health funding.
And I introduced myself a little bit in the beginning, but I am also a clinical psychologist and the director of the Center of Excellence for Eating Disorders. But I think I also have an unusual experience in that I've built and directed centers on 3 different continents. So I have sort of inside-out knowledge of healthcare systems in New Zealand, in Sweden, and in the United States. And I think you could probably see by some of my interviews on the documentary, I get a little passionate about this topic sometime. because one of the things that I really like to focus on is doing whatever we can to minimize the amount of time that a person has to live with or is exposed to their symptoms. And I've seen so many situations where poor treatment or non-evidence-based treatment has just prolonged how much time, how much of their life they have lost and really can't recapture. So I think one of the things that I'm really dedicated to is the delivery of these evidence-based treatments so that we can minimize the amount of time that people have to be exposed, not just the patients, but also their families, to the pain associated with mental illness.
Can you guys hear in the back very well? Because the speakers are all up here. It's not being projected on these speakers, so it sounds loud to us. So if it doesn't sound loud to you, just tell
move
us.
forward or let us know.
Yeah.
Yeah. I would like to just make a comment before we start taking questions, if I may. I know there was a lot of discussion about evidence-based practice in the film, which I highly advocate. But there are a couple of things, too, that really resonated with me. And one in particular was one of the gentleman's comments about privacy is one of the most overrated virtues of modern times. And our son didn't receive his diagnosis until he was 24 years of age, so legally an adult, and by all rights, we could have been completely shut out of his treatment. I think as a parent with a chronically ill child already, we were fairly actively engaged in fighting for him and for his treatment. And I think it is equally, if not more so, important for individuals with mental illness, as they talked about in the film. And it's one of the great things about the program that we got our son into here at UNC, because they had what they called multi-family treatment, so that there was an opportunity for parents to engage with each other. At one point, we were more involved with his psychiatrist, but because we had a bit of a disagreement with our son at one point where we were demanding that he get drug tested, and he said, well, I'm cutting you out of my treatment plan. But we kept fighting and speaking or reaching out to his psychiatrist even if she couldn't tell us anything. And I think that's really important, because in the scheme of a 10 to 15 minute visit, our acutely psychotic son could hold it together. He's intelligent, he's charming, and the physician didn't always see the same thing that we were seeing at home. And I also pushed back on the HIPAA front many times and reminded his psychiatrist that her first obligation was to do no harm. And so if she was reducing the medication and we saw him becoming actively psychotic at home, we would reach out and say, okay, you don't have to tell us what's going on, but this is what we're seeing. And so I just think that's incredibly, incredibly important. Because it can be very difficult for a therapist to know when they're only speaking to someone that may not have a lot of insight. And so I encourage everyone to reach out, to further explore your HIPAA laws if you don't fully understand them, to remind the physician, as they were talking about in legislation, and to become actively engaged both in the state and at the national level with regards to advocacy. I was just down at the General Assembly a couple weeks ago speaking at the Behavioral Health Services Committee, and they're pushing for more and more therapists. In this area, we're fortunate to be in an evidence-based type of treatment area with academic institutions here, but in rural parts of the state, we don't have the same luxury. And the General Assembly members were expressing concern that groups like Alliance and other managed care organizations have closed networks. Well, a closed network is one where you're trying to credential your providers and make sure they're providing evidence-based practice. And when our legislators don't necessarily recognize the importance of that, it is important for you to be speaking out and letting them know what's important to you as people who are advocating for your loved ones. So.
That's why I married her.
Any questions from the audience?
I have a question. Do I have to come?
I think we can hear you. We can always repeat it if we can't.
We
hear it.
can't see you very well, so if you
That's
could
okay.
stand up,
not
then we'll
sure.
know where to look.
Did you have to go get the guardianship for your son to be able to, for the psychiatrist to talk to you, or, we've been in the same situation, but we were forced to go for guardianship, so they won't ship it. The state would not get custody of him. Things happened in an older age, and unfortunately, he was too old, and they won't talk to us.
How old is he?
Now he's 29, but he was, he went to psychosis when he was 17, so now it's been like 12 years. They're dealing with that. I'm very happy now. There are a lot of medication. That's the only problem. Other than that, I'm thank God to UNC Chapel Hill. They saved our life. They're the best of the best.
Yeah, I mean, you can, every situation is so incredibly different, right? And some folks, I know there's some people in the audience that have had to consider going down the guardianship path. We never had to do that. And that's where you really want to be reaching out to different experts who can advise you. That's a big step, right? And so those are always the kinds of things you want to think about very carefully. I think a lot of your ability to intervene when your children or your adult children are no longer minors, the relationship that you've developed with them up until that point has a lot to influence as to what kind of sway you hold over them. Our son trusted us on many levels for his medical care because he had been through 4 open heart surgeries before the age of 16. So I think that gave us a little bit of a leg up, that he thought we probably were going to be there for him. But each situation is different, and so it's hard to know for sure how to advise anyone.
He was in psychosis. He wouldn't even know who we are at the
Yeah.
time, so we had no choice.
Yeah, I know Pam is sitting there in the office.
Yeah.
Yeah.
Thank you so much.
Well, I would like to answer that question in relation to my own experience. My daughter actually had anorexia when she was in junior high school. This was, doing math, I think over 20 years ago. And we went to the UNC eating disorder clinic, and she wasn't doing well at all. And I took her, and I remember just seeing this kid fade, and it looked like someone from a concentration camp. And I remember getting her to gain 2 pounds. I was so excited to go back to the eating disorder clinic at UNC to announce, oh, she's gaining. And I was reprimanded because the food she was eating was not appropriate. And we were then fired as a family because we didn't have a quote-unquote leap of faith. And they gave my daughter or me a pink slip and said, here's some referral. I then seen my daughter basically look like she's dying, now losing this relationship with whoever she was talking to. I do remember her face, and there were 2, a psychologist and a nutritionist. And I got on the phone and went crazy in terms of calling everybody's boss. And I just remember going up and down, up that line. Who's your boss? Would you do this if your child had a kidney malfunction and get a referral, and you have to go and find some doctor, and you're not having any accountability or any communication to bridge that gap? Would you allow this if this were a regular, a physical illness? Not to say that anorexia isn't a physical illness. So I ranted all the way up the line, kind of gave up, and someone at the top, I think it was the dean or somebody, it's all a blur. But I remember him saying, "You're right, this shouldn't have happened. And I will find you a doctor that I think can help." Well, out of the blue, Dr. David Jones from Duke University, and I don't know if you know him, but he's world famous, and I don't think he's alive right now, but he's called from Duke, and he said, "I'm Dr. Jones, and I understand you have a problem." It was such a wonderful breakthrough for me that I could tell him, "This is what happened." He says, "You need to come in now." So I went in with my daughter. She was underage, so it was a whole nother story. But, I mean, she was 15. So I brought in my daughter, and he says, "Oh my God, she's got to get in this hospital now." Now, I'm glad to hear, the UNC Eating Disorder Clinic somehow went defunct, I think. There was a gap. I don't know what the history was. So I'm glad to hear that it's functioning with somebody who seems knowledgeable. But I'll tell you, if it weren't for Dr. David Jones at Duke, who had a completely different view of how to handle anorexia, and his idea was you have to break through the safe weight. And so we went through quite a bit of months of turmoil because my daughter was not going to gain weight. But at some point she made that break, decided to eat. It's a story in itself, and it's a wonderful story. So she got through anorexia and became a healthy, functioning, wonderful woman as she is now. But she went into a psychotic break in her third year of medical school. And what we were told was, and this is important for all you young kids, what we were told was that if she were anorexia, she never should have been given Adderall. I know that a lot of you here are on Adderall if you're in college, probably many professionals. But that lack of continuity and the continual continuity that we had, the lack of continuity that we had over 7+ years, has really been a passage and a discovery of the complete disconnect between one group of specialists and another, and the lack, almost ego going on. And so when I was watching this film, back to this thing, I had to go and get a court order and pay a lot of money to get a temporary guardianship. Because there's no way a psychotic person where you're committing them because you think they're gonna hurt themselves. They're not saying they are. So you think they're in trouble, you're trying to help them. And I remember having her assessed, and oh yes, she needs to be in the hospital. So this is in another state, and I'm calling the hospital. How's she doing? Is she okay? We can't tell you if she's even here.
Right.
What
Yeah,
an
that's-
amazing disconnect. I couldn't get to the table. I couldn't say, here's what her history is, here are her meds, nothing. It took money and common sense and an absolute drive to, I'm gonna get to this table, we're gonna get her well. Now, you know, I often thought, as many different times I've been in different hospitals as a result of this passage, what do people who don't have resources do?
Mhm.
Yes.
That's really
Yes.
important.
They
Right.
die.
Yes.
And I'm not too sure that, you know, even people, well, obviously from this film, they die.
Right.
And so what I thought was really, so bottom line is temporary guardianship is really important, not necessarily permanent, but temporary. Because it is a real bad thing to have, you know, full guardianship. It creates all sorts of issues for them if they want to get jobs later on.
So what do you think, Cynthia?
I was just gonna, you raised so many important points, and your story illustrates on a very personal level so many of the topics that came up in Josh's film. But the last point is the one that really hit me, and that's also the similarity between Cynthia's story and your story. The two of you advocated like crazy. You even advocated at times when you were at loggerheads with your son, and you didn't stop. And you're right. If you have a mom or a dad or a guardian who will do that for you, that's great. But that's not always the case. And often parents themselves have difficulty. Or they might have their own mental illnesses that they're dealing with, or they might not have the resources or the wherewithal to even know how to go up that ladder of bosses. And on one hand, Cynthia, you are so right. Talk to professionals, talk to a lawyer, but also talk to other parents. And I think that's one of the things that we've seen so much in the eating disorders field over time. You mentioned multifamily groups. We have multifamily groups for our parents. There's a wonderful organization called Feast that has gone global, that unites parents around the world who are struggling with getting treatment for their children with eating disorders, or just how to manage your child if she or he gets out of control when you're trying to renourish them. And it's so empowering for parents to get information from other people who have gone through it.
Right.
On one hand, it's super to get that information from practitioners, but when you can sit down with someone else who has been in the trenches and gone through it, just like your story, and can say, hey, try this, or hey, try that, or hey, try temporary guardianship. These are things that, again, we need tools. As much as evidence-based care gives a patient tools to deal with their mental illness instead of dealing with, conflicts and insight and all of that, which I'm not saying is not important, but we so need tools. Parents and partners also need tools to advocate on behalf of the person who has the mental illness. So
Right.
Thank you for sharing your story. And Ed, did you have something you wanted to add on top of that?
No,
Okay.
you covered it. So. Any?
Question about something they talked about in the film. I have a mom that has schizophrenia and she struggled with it most of my life, and she is not better at this point, like 20, 30 years down the road. And one of the challenges that we have is the HIPAA and the privacy. And I know that there was some conversation in there about whether or not the confidentiality is as strict as maybe it seems it is, and are there holes in there that would allow someone like me, for example, to get more information than I think is available today about her stick scenario when she's not willing to turn that over, And this is another resource thing too, so there's, I guess, two parts to the question. She lives in another town, and if I want to move her to Raleigh, where I live, there's a 5-year waiting list on housing. So I don't want to apply for guardianship and have her be hours away from me where I can't care for her, I can't take her to appointments, I can't go to the doctor with her, I can't watch her. And it's difficult when someone is psychotic to move them in with small children into my home. And so there's a very difficult decision that has to be made whether you leave somebody like that on their own, or, we can't afford housing for her to pay for out of pocket. So trying to make the decision of applying for guardianship for somebody that's in a scenario like that, where you may not be close enough or have the resources available to care for them, then maybe guardianship is going to put you where you're not being a good guardian. Does that make sense? I can't be a good guardian that far away, and I can't move her here because housing is so limited. And where are there resources available, if any, to help guide me to, or anybody really in the same kind of situation, to get her closer where I can take care of her, but I'm not paying for a facility that costs $5,000 a month. Or
Do you live here in Chapel Hill?
I live in Gardner, so the Raleigh area, but she's out towards the Charlotte area. And honestly, she was homeless for many, many years, so I'm nervous to even uplift her from where she's stayed for several years now, because she's actually staying put for a while. So that decision to move her is big, really, really big. And if I don't have a support system set up around me to move her here, I feel like I'm going to explode this safe scenario that she's been in, but she's mentally not well, And so it's a very difficult decision to become a guardian of somebody who is resistant against it, and to fight,
Right.
Then I fight her in court and she's angry with me, and now we don't have a relationship now. But are there resources available to help somebody with all the pieces, like the housing puzzle and the medical care puzzle and the finance puzzle, to know that we're making the right shift for someone like that? Does that make sense?
So those are all really difficult questions. I guess, this is where a lot of it gets into the nitty-gritty of what kind of insurance does she have?
I mean, she's Medicare, Medicaid, what
Does she have Medicaid? She has.
I believe so. I mean, she's on SSDI and she has no income and no assets.
Okay, and
That
so I'm
should be-
assuming that Medicaid is providing her health care benefits now. And is she in What kind of facility is she in now? Is it a group home or a,
It's over age 55, senior government housing.
are they providing health care? Is it a healthcare facility or?
Charlotte Housing Authority, so it's public, it's just public housing. And it's not, she's been in some pretty sketchy scenarios and,
Yeah.
Financially for a family to take that on, I've looked at facilities that are $3,000 a month, and you can't even take care of somebody in that kind
Right.
of scenario, but the public programs available are very hard to understand and very hard to find good ones, and
Right.
I have a little bit of a suggestion, maybe, I don't know. I know somebody who recently took her son out of a group home, he had autism, and got an apartment for him in Chapel Hill and has people coming in to see him. So I don't know if maybe you could have somebody checking, a healthcare provider, checking on your mother a couple times a day, Meals on Wheels, a little bit more closer contact with her, who will report back to you. And that might be covered under Medicaid, Medicare, because she's sort of a safety issue and,
I can put you in touch with a couple things maybe after this. I mean, a lot of it depends on what level of care, what kind of insurance. There's so many nuances to these questions. I think one of the things that folks don't realize, I mean, they talked about health insurance parity there, and that was supposed to be part of the Affordable Care Act and everything, but health care parity for mental health is still a bit of an oxymoron, quite frankly. And each dollar that goes towards paying for services has enormous amounts of constraints on it. So, I often tell people that in North Carolina, at least, people on Medicaid have a far more robust package of services through Medicaid as a provider than private insurance, and certainly a whole lot more than people that are uninsured or underinsured. So it's when you start getting into the nitty-gritty of each individual circumstance when you truly find out, well, I can get this service paid for, I can't get this service paid for because it's the law, okay? But I have some phone numbers I have some materials with me, actually, if you want to talk after this. Again, a lot of it's going to depend on your mom's individual circumstances, and there's no blanket answer of there's a quick and easy way to make it happen.
I have just a quick question. Are there any plans for this to be nationally distributed, this documentary? Do you know plans?
I think it's
see
an
who's
Amazon.
saying.
Could whoever's speaking just raise their hand for a second?
Oh, right here. I'm just wondering,
Oh, you're
are
way back
there
there.
any
Okay.
plans to distribute this
I can't
film
even.
nationally?
So it is right now on Amazon. So you can rent it on Amazon for $1.99, and then it's also on Canopy. So most universities have access to it for free if you have a library card. Also, quite a few public universities have access to it for free with a library card. So that's how it's being distributed currently.
Thank you.
Were you thinking about something in particular?
Well, I was just wondering if it would be something approach public television to air?
I mean, yeah, we'd be interested for sure. Television's a little bit tricky, but yeah, I mean, there's local PBS and national PBS, and there's some constraints with it. But if you have connections or want to talk with me, we can definitely talk.
And
But yeah.
I guess you guys have done this in Cary, haven't you? I mean, and is there another plan, are there other plans to kind of have Josh to
Yeah.
have some screening and maybe connect with, other organizations like NAMI and all those folks?
Yeah, we've worked with different groups. NAMI in North Carolina hasn't been supportive of the documentary for whatever reason. We did contact them, and they did watch it and haven't supported it.
When
I
did
don't
you
know.
do that? Because they've had leadership transitions.
I don't know. That was back when we were starting, so I don't know.
They have a new ED.
Okay.
Yeah.
So I don't know. That was way back when we were publicizing it locally. At this point, we haven't put that much effort into it because we're working on a new documentary and putting most of our effort towards that. But we would love to get it to do more. We submitted it in film festivals around the country, and those are all pretty much over. So we've done most of our distribution work right now, but we would we're networking with a lot of people, particularly in Colorado, a lot of different groups, and to create a series of 5-minute documentaries that parents would watch as they were growing up. Right, they have a child and they watch documentaries about teaching mental health skills at different appropriate ages. And so we're producing those documentaries. So that's the effort, that's the work we're doing right now, and the networking we're doing right now. But this documentary's out there and we would love to promote it if it helps anything.
So I'm gonna put somebody on focus right now, and somebody mentioned something about CBT, which is cognitive behavioral therapy. We actually have an expert here, Janice Bainbridge, and she works at the UNC Center for Excellence in Community Mental Health. Can you kind of briefly explain what that is, Janice?
You did not tell me you were going to do that. I'll try. I feel like I should.
Do you want to use the?
Yeah, we did.
Stand that way. Where does my
It's all evidence-based. I love that word now.
Yeah, so this is hard enough for me to do.
There's a mic there, Janice.
Prepared and, can y'all hear me?
Yes.
Okay. Okay. Yeah, this is hard enough for me to do, prepared in front of people that I do know. So CBT, so the thing that I'm more expert in is DBT, dialectical behavior therapy, but I can probably describe cognitive behavior therapy a little bit. Anyway, it's an evidence-based treatment for depression especially, although I think it's got uses for other kinds of mental health disorders now as well. And it is, so let's see if we do it. So the part of the way that it works is that there are connections between what people feel emotionally, what they do behaviorally, and how they think. So that so that the way that you think can shape how you feel, and how you feel can shape how you think, and both of those can affect what you do, and then what you do can have ripple effects either in a positive direction or a negative direction. So when you're in CBT therapy, a lot of what people learn how to do is identify what kind of thinking they're having. So some kind of cognitive distortions that we think about as common, which we all do sometimes, are things like catastrophizing things, like thinking things are just horrible, going to be horrible forever, that you are predicting the future in a negative way, that you have mental filters where you see all the negative things and you discount all the positive things. So there's lots and lots of different things that we all do in our thinking that can not really reflect the facts of a situation and can distort things in a way that can make us more depressed. And when people are depressed, they tend to have more negative thinking, and so it sort of perpetuates itself. So then when you think about like changing how you think and then also changing what you do, then you can start to have improved mood. So there's other experts up here who might add something to that. Does that describe
Christine,
it?
do you want to add
Yeah.
something?
Yes.
I'll add a little bit to that. I think, Janice, you did a wonderful job of explaining the core tenets of CBT, but essentially there's this idea that all of us, whether you're struggling with depression, anxiety, even if it's just regular old stress, you sometimes fall into these thinking traps, these thinking errors where you might be catastrophizing, or you're only looking at the negative side of things, or you become convinced that you can read the future, those sorts of thinking traps. And a lot of times when you become really trapped in those, you start to feel a certain way, whether that's feeling depressed, feeling anxious, and it's hard to get yourself out of that pattern. So cognitive behavioral therapy is designed to help kind of break that thinking pattern, break that connection that you've been making over and over again, so you sort of retrain yourself in a different way, and that helps downstream with feeling really negatively, doing behaviors that might reinforce your depression, etc. And it has been tailored for lots lots of different diagnoses. So we know that cognitive behavioral therapy is effective for the treatment of eating disorders, depression, anxiety across the spectrum. It's something that we use at the Center of Excellence for Eating Disorders kind of as our frontline treatment for folks that are coming through our doors. So it's something that I think is one of those treatments, like you saw in the video, you can ask, what kind of treatment are you delivering? And cognitive behavioral therapy is one of those types of therapy that has shown a very strong evidence base for mental health disorders kind of across the spectrum.
Awesome.
Can you just say one more thing about eating disorders with CBT? How would you do that? I mean, that's sort of like an OCD more, isn't it? It's not so much of an anxiety, or is it? I know how you can do that for depression.
Sure.
And anxiety, but sometimes people have eating disorders maybe who aren't necessarily depressed.
Yeah, absolutely. No, that's a great question. So when you talk about applying cognitive behavioral therapy to a specific disorder, whether it's eating disorders, depression, you're kind of zeroing in on the specific thoughts. So for example, in eating disorders, there might be cognitive distortions or thinking traps around good food, bad food, around being thin is good versus being not thin is bad. So cognitive behavioral therapy for eating disorders is designed to break those kinds of thinking traps so that then your behaviors start to change as a result. You're not restricting food, you're not engaging in binging and purging, those sorts of things. So you're right, there is a lot of overlap between kind of that obsessive compulsive kind of flavor in addition to what's going on with eating disorder psychopathology. But we found that for the treatment of bulimia nervosa, for example, cognitive behavioral therapy is very effective at being able to get people back on their feet, getting them to stop binging, purging, or whether it's exercise, other sorts of things. So there's a very strong evidence base for that. I would say the other thing that we use very commonly at the Center of Excellence for Eating Disorders is family-based treatment for anorexia nervosa, particularly in adolescents. And as these folks up here have talked very eloquently about involving families and how important that is. It is something that we try and incorporate both on our inpatient unit, but also on our outpatient unit for folks that are struggling with anorexia nervosa.
We have 2 questions.
I think you had your hand up first, ma'am.
Can I just go finish
sure.
CBT?
Yeah.
One more thing about CBT, and this is related to Josh's current project. I often think about, we use CBT to treat all of these disorders, but I actually think CBT skills should probably be taught in school.
Yes.
Because, especially what we're seeing with kids and, so many AP classes and so
Yes.
much anxiety and suicidality. I mean, these are living skills, not just sort of a tool that you need in psychotherapy. So I would love to see this get into the curriculum somehow.
There's one there.
So I have 2 questions. So I'm interested in DBT too, because I don't really understand what the difference is between DBT and CBT. So I would appreciate if you don't mind, again, commenting on that. That was my first question. And then I'm also curious about whether or not CBT, DBT is effective for the treatment of schizophrenia, or if there are other treatments outside of your typical drugs that are effective in the treatment of schizophrenia. Just 2 completely different questions, sort of, kind of.
Would you like to go back to the mic for the DBT, CBT question?
Yeah, sure.
She's gonna hate me.
Dialectical behavior therapy, and it does incorporate a lot of elements from CBT, so it's sort of like the DBT is here, CBT is under it, and does, so you do CBT in DBT, but it also has some other elements to it, and dialectical means sort of a balance, sort of middle path, middle ground synthesis between opposites, and so one of the main dialectical stance in there is the balance between acceptance and change, because the people for whom DBT is good therapy for often struggle with if you're trying to change all the time and it's hard, you can get demoralized and depressed and feel bad about yourself, and so you have to also have self-acceptance, but if you stay in self-acceptance, then you don't change and grow in the ways that will improve your life. So that's what the dialectical part means. And it also goes with skills that are learned. So the skills are how to regulate your emotions so that you have more positive emotions, fewer difficult or problematic emotions, and reduce kind of improve your resiliency to emotional pain in some ways, or just circumstances, how to get through crises without making things worse for yourselves, or to kind of distress tolerances, what we call that. And then also interpersonal effectiveness skills, so learn how to get what you want, what you need from other people, nurture relationships, and relationships when you need to, and maintain your own self-respect and stand up for yourself when you need to. And so then it also goes, just one more kind of piece, is that that's in the skills group, and it also goes with individual therapy where you're doing lots of CBT kinds of things, reinforcing the skills, and also targeting certain behaviors that are related to your goals. So obviously with people who are suicidal or harming themselves, that's a target, to sort of not do those things so that you can, the whole goal is to build a life worth living. And but there could be all kinds of things that you target to either things that you want to do more, things you want to do less, and how do you do those things, and to figure out what are your patterns of thoughts, feelings, and behaviors that get you there, and what can you do differently, and all different kinds of ways to, instead of going from California and you want to go to Maine, you end up in Florida, how do you get yourself going up to Maine instead? So that's a nutshell, I guess, of
For schizophrenia.
Did
David had a DBT and schizophrenia?
No. Can I say something?
Sorry. Yeah, thanks. So, question, I guess more from an academic standpoint, especially for the two researchers or clinicians on the board. So I work at Veritas Collaborative, the Eating Disorder Hospital in Durham at the adult facility currently, and I feel like I kind of resonated a lot with what was said in the documentary about, especially with the girl who had anorexia. But I think particularly I'm interested in finding solutions to these like really overarching problems, and I think some of the solutions that were proposed were like evidence-based treatments and then like the questions around confidentiality. But I was really curious to hear what other solutions there might be out there, particularly y'all's opinion on outcome reporting, and if that is effective or ineffective, and any other solutions that might be out there.
Want me to dive into that one?
Go ahead, Bob.
I think it's a really good question. And, I think one of the things that Josh highlighted in the movie is the differences between a for-profit organization and an organization that is not for-profit, but that delivers evidence-based therapy. And I think we all don't do a great job at outcome reporting. And I know when my kids have had physical illnesses or psychiatric illnesses, and I've had to go somewhere, like I want to know how well the place I'm going is actually treating people. What are your stats? How many of those operations have you done? I want data. Part of that is just like my research brain. But I think any parent should be able to ask that. You want someone to do heart surgery who's done thousands of them, not for whom they do like one a year or two a year. Part of the issue that we've had with outcome reporting is getting organizations, both for-profit and non-for-profit, to agree on what the metrics would be that we use. There is no standard metric that is used across different eating disorders treatment programs that can indicate which one's doing better than another one. Part of that is because businesses are behind some of them and they don't necessarily want to reveal things that aren't really positive. Another thing is the nature of patients that come into different programs really changes what the outcome is going to look like. So at UNC, we're very much a tertiary care institution. Another place, like there's a place in Denver that is even a quaternary care institution. They get incredibly ill people. And their outcome statistics might actually look worse than a place like Veritas, but that's because the people going in the door are so much more severe. So there are all sorts of questions that go into how does one actually develop outcome reporting that captures all of those factors and is really fair to patients, to parents, and to the institutions in saying this is how well this group does with this problem. But I think one of the things that would be a really important thing to do, again, on a higher level, is if there would be a way to get for-profit programs to actually commit to delivering evidence-based therapy. that would sort of be a meeting of the minds in some ways, because if there's a way to blend profit with evidence base, that seems to be a future that would be good for everyone. The problem is it costs money. And I think that's what we saw in the beginning. To deliver evidence-based care, you need training, and you need to keep your skills up. I think one of the things that was really clear that Bill Pelham was talking about is some people get trained in graduate school and they never get any more training. And if I had done that, I'd be doing some psychoanalytically oriented psychotherapy and, being kind of lazy in the work that I do. It takes work to keep your skills up to snuff. And it also takes money. And those training opportunities have to be there. And right now, to get trained, you often have to go somewhere, and you need to spend a lot of money, and our institutions generally don't pay for us to get that kind of training, so it's off your own dollar. So part of what we're actually trying to do is to develop some more web-based training where you can really get live interactive online training to up your skills. We do continuing education training, but that's not the same as sort of upping your therapy game, and really making sure that what you're delivering is current, right now, state-of-the-art treatment. I kind of went off on a tangent there, but hopefully that got some of the issues that you raised in your question.
The guy in the back.
If I could just add one thing, though, to what Dr. Bulik was saying. I think part of the challenge is that there also seems to be varying definitions of what evidence-based practice actually means. The reality is that the American Psychological Association has a division that is solely dedicated to gathering evidence and developing what we call evidence-based practice. Evidence-based practice or evidence-based medicine is not one study came out about a particular thing on, they studied 12 patients and they found X, Y, or Z results. That is not evidence-based medicine. Evidence-based medicine has to be a collective pattern of results that all kind of are showing you the same thing. So I'll take CBT as an example. There have been hundreds, if not thousands, of trials of cognitive behavioral therapy for depression. And the evidence over the years showed us over and over and over again that it was consistently effective for the treatment of depression, consistently effective for the treatment of anxiety disorders. So I think that until we all come to a firm understanding of what evidence-based medicine, evidence-based practice actually means, it creates that gap and it makes it even further for some folks. So I think that just being well informed about what that definition actually means is a really important piece of all of this.
Can I say something about that?
Sure.
Sorry. So in making the documentary, that's one thing we were careful about, actually, because evidence-based treatment and evidence-based practice are different terms. And so I just think evidence-based treatment is treatment that has evidence for it. Evidence-based practice is a method for evaluating research, right? It's about how do you look at the research, how do you evaluate it, how do you rank it? And then from that, how do you select what treatments to use? And so developing that method is really important, and improving that method. Because none of our treatments today are as good as we want them to be 50 years from now, right? So it's got to be forward-looking. And then I did want to make a comment back towards the question about what's effective treatment for schizophrenia. And so this is a broad answer that if you go to goingsane.org, we created, because we felt like people needed a place to go after watching the documentary, that's why we created this website. And it's a mile wide and an inch deep. So the goal is simply to say, here are a bunch of mental illnesses. These are treatments that have evidence-based, have a trustworthy evidence for them, and then resources that you can go and look into what that treatment is and what it should look like. Because just because someone says they're using that treatment, doesn't mean they're using it correctly. So we're not pretending to be experts with GoingSane.org. It's simply a mile wide, inch deep. So it just gives you a first step. So if you want to know what treatments have good evidence, you can go there and find out.
I think there's one.
There's a man in the back.
Yeah, the man in the back.
Goingsane.org.
Okay.
Yes.
Man in the back.
Yeah, my question is about whether this is a uniquely American problem or whether other countries have dealt with similar issues and maybe had success solving them.
I'll give one fun answer to that. So if you are a psychologist or a psychiatrist in the United Kingdom right now, your work generally gets reimbursed by the government. You will not get reimbursed unless you're doing an evidence-based treatment. So if I said I was just going to go out there and do equine therapy for anorexia nervosa, or even something sort of less extreme, there would be no money coming in. So I think they've actually done a really good job of cracking down on that. All countries aren't like that. Sweden, where I spend half of my time, is much more evidence-based, but you still have practitioners who sort of go off in strange directions. But I really think, and this is something for the insurance companies to have to consider, is having reimbursement tied to whether you're developing or delivering evidence-based treatment is probably the way of the future and should be the way of the future.
Go ahead.
I just want to make a comment from my own experience. And it just seems like we're so far away from this outcome-based reporting and tracking. Just for me, trying to find, and I think you spoke to some of this, the complexity of what, say, an institution, how effective an institution is based on the particular treatment, right? Just finding out what institutions are out there and geared towards a particular mental health situation, to cater to my case, it was my child. In this sort of litigious environment that we're in, I could not find a single person that would give me an opinion.
Hmm.
It truly was. I finally landed on, and I can't even remember what site it was, but it was a nonprofit organization with a website, handled by one person that was overwhelmed, a parent that had gone through it. And so I was completely dependent on trying to weed through the marketing on websites, and
Right.
talking to the one or two parents that the institution will allow you to talk to or
Right.
market
Yep.
to you. And it was really
Yeah.
really difficult. And this is not a $2,000 treatment, right? This was 12 months and college degree expense kind of
Right.
stuff. So just having that, that understanding, who's doing what, where, at a minimum, never mind how well they're doing it, right? And being able to have a forum by which to exchange personal experiences.
Right.
Right.
Not
Yeah.
say, okay, let's not get into, don't worry, we're not gonna say you're good or bad.
Right, exactly, yeah.
But, hey, where's the forum where parents, in my case, right,
Yep.
can get together and say, I had this experience with this kind of situation, that place worked, that one not so well,
Yep.
right?
I actually don't know if other disorders have organizations like FEAST. Because FEAST has been perfect for this, because parents come they straight talk. They don't mess around because they have wasted so much time and so much money. And if someone comes on to their online, they have an at the table online forum and says, help, I'm in this state, I need this, what's good, what's bad, they put it out there. And I have heard so much positive information from parents about just how valuable that is. And I think it would be great if other disorders had similar organizations, but I just don't know if they exist.
I think relative to schizophrenia and I think NAMI is.
Well, mental health in general, depression and.
Depression,
The
yeah.
National Alliance of Mental Illness. I do think parents are a great resource. And, healthcare in this country is just fragmented completely, regardless, whether we're talking about behavioral health issues, even in physical health conditions. And that situation is not getting better when you look at what's happening, at the federal policy level. So I think we have enormous challenges. I was just at a population health conference yesterday, and more and more the life expectancy in the U.S. is going down, even though the amount of money we're spending is going up relative to countries like Cuba. So we've got huge challenges in this country, and behavioral health, I think, is really at the bottom of the rung of how things are working. So again, there's no easy solution or quick fix to this. You just, as a parent or as a family member, you've got to be diligent, you've got to fight, you've got to be informed, and just Not, they said it in the film, one of the individuals, people changing the system are parents and friends no longer content to stay in the waiting room.
And one last thing for that I'm going to say, because I think we're going to be closing here soon, right? But as a parent, when this happened 12 years, 13 years ago, I was devastated personally. I thought, I didn't know what to do. And, Cindy worked at Duke, and I was a professional, and even at that level, we didn't know what to do. And as a parent, you need to keep fighting, as Cindy said, and at the same time, there's, continue to hope that your son or daughter will recover. And I think they will through your family support and making sure that you go to a place like UNC that has the evidence-based treatment that your kid, will need. So,
Thank you.
I have two questions.
We have 2 text questions. I think we probably have, that's probably going to be it.
They're pretty straightforward.
Okay.
I just want to make sure we can text and then that.
Okay.
So the first one is, well, I shouldn't be straightforward. More accessibility for parental involvement would be great, but what about parents who have very ingrained stigma or shame about mental illness? What about parents who would deter children from treatment if they were aware of their child's illness?
that's a very tough question. When my son was diagnosed, we lost friends. He lost friends, and people didn't want to talk about it. But I made a decision, and I think Cindy would agree with me, that in order for you to break the stigma, you have to talk about it. I always tell people, that I have a son who's mentally ill, and the more you talk about it, I think, and trying to educate them that it's not something, the part of the issue is that you only hear somebody with mental health issues when there's a shooting somewhere. They always blame somebody, oh, he's got a mental health issue. So, you need to talk about it. And when I went home to the Philippines, in the Philippines where I grew up, the stigma is incredible. I have 5 sisters. I sat them all down. I started crying in front of them because I was embarrassed. So you have to really talk about it and bring it to the forefront, and you'll find new friends. I'm a good parent, by the way. So they told about that people are blaming. I'm a good parent, and because I blame myself when this happened. It's like it was my fault. I was like so depressed about it. It's like, what did I do wrong that my son, who's the president of his high school class, now has schizophrenia? It just devastated me and our family, and thanks to our family support and thanks to my wife, then. Know we're a little bit better. So.
And I would just add to that, the stigma overcoming that's a real process. It really takes time, and it's not easy. And we did lose friends, and so did our son, like Edward said, but we made new ones, and multifamily became our new family of people that had been through life experiences like us and had been in the trenches. And I guess the other thing I would say is it has, not that we would ever choose this for our family, but it has enriched our experience in ways we never could have predicted, and there's grace in that. So you just have to try and see both sides.
Can I say something real quick?
Yeah.
I think going without parents involved is like a last resort. It's a lot easier to get a parent involved, to teach them how to be involved, than to go without. So that's the last resort. If so, there are other people that can support and act as supports, but you need supports in most situations.
Yeah.
You need to get other people involved. But again, that shouldn't be the default. You shouldn't jump to parents are probably the problem, right? That's normally not the case. If it is the case, ideally we can teach them. So it's just really a last resort where you would go without them.
Cindy, can you give your information if you have any questions so we can text you?
Sure.
Yeah, actually, Kate, if you would like to text more questions to Kate, one of the things that we'll do is, we'll do a blog post on tonight. And what we'll do is if there are additional questions that come in through the text, we'll answer those questions on the blog post. And the best way to get people to know about about where to find the blog post would be, what do you think?
Through our Facebook page, probably?
Yeah, maybe through the Center of Excellence for Eating Disorders Facebook page. We will put a link to the blog post.
Or Twitter?
We'll tweet it and we'll put it on Facebook, and then you'll be able to see the answers to the questions. And I might draw on the panel to ask for a little bit follow-up if some of the questions are in your
Sure.
areas of experience or expertise.
I have cards here too, if you were interested in
lovely.
calling us and so
Yeah,
forth, so.
lovely. But I think we probably, before we stop, I would just really like everybody to acknowledge Kate, who was the person who just gave us the questions. She brilliantly arranged this tonight and got everything organized with the varsity. And also, just my sincere thanks for the panel members. You all brought really valuable experience and information, and I'm so grateful that you were able to come and share with all of us. So thanks to everyone. And thank you all.